So we're just going to take a moment to talk about the concept of patient-active diagnosis and patient-active treatment. Now, the reason sometimes that you may need to do this, obviously I'm right in front of the patient, I'm with the patient. So in situations in office where a patient's too tender for you to actively move them, or sorry, you are active and the patient's passive, so essentially patient passive treatment, for you to move them, they're too tender, or they're too essentially afraid of the pain that will come from you moving them. So you can use a patient-active diagnostic approach and a patient-active treatment approach. Also, if there's a situation where a patient's in trouble, they need some help, but they have an issue with transportation, they can't get to you. If they have access to video conferencing software, there's the possibility that you can have a positive interface with them. Also, you can teach them how to do certain things such that they are then able to self-diagnose and self-treat on some level, especially with larger motions. Right, so we're just going to use the neck as an example here. So obviously I'm in the shot, but I really have nothing to do with this aside from the communication with the patient. So what we're going to have you do is we're just going to do our testing. So we're going to have you turn your head to the right and turn your head to the left. So we have a comparative. Now comparatively, so what I'm actually going to do is I'm going to ask the patient what felt better. So what felt better, turning to the left or turning to the right?
It felt better turning to the right.
Okay, so he felt better turning to the right. What I noticed as far as visual asymmetry, there was a greater ease of motion to the left. Now, I'm not palpating, so my ability to confirm that is not as high, but this gives us the opportunity to have an example of what I see and what the patient feels don't always match. So the patient has their scale, and we have our scale. Our scale is motion, the patient's scale is subjective sensation. So what we want to do at this point is once we have essentially our diagnostic, if you're not with the patient and you have a harder time getting a good angle to see this, then your choice of direct and indirect may not be as clear. But what we're going to do is we're going to say that if you want to go indirect, or if there's pain, you go indirect first. If there's no pain, you go direct first. Or you can go direct first if you want to remove the choice. No matter what happens, just go indirect followed by direct if you want to remove the choice. But in this case, what we're going to do is we'll have you cross your arms. Okay? I want you to, now it's going to be harder to see the patient. So actually what we're going to do, bring your arms down just for the visual. Okay? We want you to turn your head to the right because it was easier for you and comfortable. Okay? So he's there, right? He's in a more comfortable position for him. That feels reasonable?
Yep.
Okay, so I just want you to take your right shoulder and push it straight backwards. Good, and relax, and then push your left shoulder straight backwards, and relax, okay? Now, what we're doing there is we've got position for correction, so the head's turned to the right, or position to ease, realistically, and then we have relational motion, so the shoulders move. Shoulder goes backwards, head stays relatively still. Did one of those feel nicer to you?
I wasn't paying attention.
Fair enough. Doesn't matter at this point, right? So there's the opportunity to get the visual information. From where I am, the visual information suggests that pushing the left shoulder backwards does more, but it may not be as comfortable. If I'm trying to keep the patient comfortable, we can have you push your right shoulder backwards again, okay, and then relax. There we go. Or we can say, just imagine your shoulders like a steering wheel. I want you to steer the car to the right, good, and then steer the car to the left. Right, so that's another cue, an external focus of attention cue. Okay, now what we want you to do is turn your head to the left. Okay, now you're going to do the same thing. Steer the car to the left, steer the car to the right. Right, so that's our relational motion. Come back to the middle. Right, now the visual, because of the angle of the camera, this isn't going to be as easy to see, but we want you to turn to the right as comfortably as you can. Cool, and then turn to the left as comfortably as you can. Cool. Okay, so still moving better to the left. Right? How did moving to the left feel this time?
It felt more balanced.
Okay.
To the left.
So in this case, what we have as far as an outcome is the patient is reporting a better outcome than what I see. So again, the patient scale is going to matter more than mine. So I still see the patient moving better to the left, which is the same as original, but the patient feels better moving to the left compared to when they started. Okay, so here we have the opportunity to see in a short form patient-active diagnostics, patient-active treatment, the choices you might make, going direct, going indirect, having the patient keep one part still, so the head still, move the shoulders in relation to it, and then also identifying through communication the pain scale or the comfort scale of the patient. So all of these things kind of get wrapped up into an approach like this. Now, if you are curious about an approach like this, I do have an instructional video available. All you have to do is contact me, and what I will do is I will leave my email address below the video so that you can contact me directly if you're interested in an educational video on patient active diagnostic approaches and patient active treatment approaches. So it's much more complete. We go through the whole body if you are interested.